Hi, good morning. Thank you, Dr. Lifshitz, for that wonderful introduction. Thank you, Dr. Goldman. Thanks to the committee and to Dr. Yaktine for inviting me to speak to you today. And we'll talk today about the poison center data, our poison center calls as they apply to caffeine and to energy products. I hope you'll find this interesting, and we'll move right into this because I have my little lights here. So there are 57 U.S. poison centers that serve the entire United States, all 50 states, Puerto Rico, the U.S. Virgin Islands, and 3 Pacific jurisdictions. The information from callers that comes to poison centers is taken in a computer database contemporaneously, and it's uploaded approximately every 19 minutes to NPDS, which stands for the National Poison Data System. This system, obviously, of NPDS data is a reporting system from callers, so it's not an active system but passive. Calls come from consumers and healthcare professionals. All the calls are answered by healthcare professionals, which are usually registered nurses, trained in toxicology. Some centers use registered nurses, some use PharmDs, and all of the centers are backed up by toxicology physicians 24/7. So the NPDS data that's uploaded comes in real time, so it's always current. And we have online data in the system since the year 2000. Basically, we have 2 types of calls. They are information calls, which are questions about substances, our events, our medical conditions, plus exposure calls. And we'll be talking today about the exposure calls. All of the information is taken down in the current standardized data set that the poison centers use. This is just a picture of the National Poison Data System website. We have in the system built in currently 131 clinical effects. That's what we term our signs and symptoms. For purposes of the energy drink analysis and the caffeine analysis that we did, there were 122 of these signs and symptoms used that were submitted by the poison centers. This is a standardized data system. In addition to the contemporaneous recording of the calls by the specialists, the poison specialists, we have a robust products database that contains over 390,000 agents by brand name and by their composition. This information comes typically directly from the companies that produce these products. In the database of the 390,000 products, there are 4,400 plus 1 products that contain caffeine, and there are 262 energy drinks and 36 energy products. And for purposes of the analysis today, we've combined the drinks plus the products, which are things like bars or such, usually. We have a controlled hierarchical vocabulary, and we have 7 energy drink codes to be energy product categories, rather, which I'll show you in a few slides. The products database depicts the products like this. This is one particular drink or shot, and it was chosen not because of the name or because of any particular interest in the specific product, but I selected it because of the amino acid that it contains, because there's been to be interest by the ingredients in the various products. So this one contains taurine, and we can see here, it's a little hard to see from the back, there's 1,000 milligrams for every 170 ml. So we can search the products database and search for calls or for specific products and their specific ingredients. Just looking back over the course of the year, since the year 2000, this particular slide goes through 2011, just to show you the exposure calls. They're in top in red, and these are the info calls. This was H1N1, these two peaks here, back in 2009, and these are animal calls. So the data, the call data, is very reproducible by time, with peaks being June, July, August, usually for the most calls that come to poison centers. Roughly, we get about 2.5 million exposure calls every year. We've noticed, Dr. Spiker and I, my colleague, we've noticed that change over time with most of the NPDS data is very consistent. The first graph here shows analgesics over time for, say, to be 12 years, and you can see there's a steady increase in analgesic exposures. The same was true for cardiovascular drugs, antihistamines, plus the sedative hypnotics that we examined in this particular data set from the annual report, last year's annual report. So our methods for this presentation today, we looked at single substance closed human exposure calls to U.S. poison centers. For caffeine calls, we were able to go back to January 2000 through 22nd of July 2013. We picked 22nd July because that was the day that we started the analysis. And we did energy products from 18 June 2010 through 22nd July of this year. The energy product generic codes were not added to the generic code vocabulary till mid-2010. So that's why it's 18 June for the first calls. We used a descriptive statistics. We looked at change over time with linear regression plus and some to be spline fit, and we correlated the clinical effect to frequencies. We used SAS jump for the analysis. So our results, the basic results for numbers of calls to poison centers from January 1, 2000 to 22 July 2013, U.S. poison centers received 48,177 calls where the agent was identified to be caffeine in some form. And then from 18 June through 2010 through the 22nd of July, that's going to be the date range for the end cut, 22 July, there were 6724 energy product calls to U.S. poison centers. These are single substance calls where the person said, I ingested or my child ingested one product. So this is the spline fit curve for caffeine exposures by day by year from January 1, 2000 to 22 July 2001-3. One can see it's not the typical change over time. It's not the typical change over time that I showed you for the previous substances. We looked at the energy products from 18 June to 2010, of 2010 to 22 July, and we see that calls, say, started out and then climbed and then seemed to be leveling off, although it's a little bit early to see exactly where this curve is going to go. And this is simply a spline fit. And these are all of the energy product calls that the poison centers received. These are the 7 generic codes for the energy products in the database. And you can see that over this time period, there were 2,664 calls, or about 40%, for energy drinks where it was contained to be caffeine only. No other substance in the composition of the drink did contribute to caffeine production in the drink. And these also included, we had a category initially for the ethanol calls, which are down here, and we had a very much a smaller number for the ethanol calls. And one thing we've learned over the course of the year, that of the course of time, that NPDS and poison center calls can be used to show the effects of product withdrawals or for directives from various health agencies. When we looked at the energy product calls, most of the calls, 54%, were the reason being unintentional. And this usually applies to children who typically are thought of the young children who cannot farm intent, but they're unintentional general calls. But after that, most of the calls concerning energy drinks were due to misuse or abuse. And those are the rest of the categories that we have for why the substance was consumed. If we look at medical outcomes, only 18% of the calls, all ages, are energy products. They had no effect. About 10% had moderate effect. That would be symptoms like tachycardia that went away. And some had very minor effect, maybe they were kind of hyperactive, etc. And these effects would generally resolve. Some of the calls were not able to follow up on because of technical considerations from the caller. There was, during this period for the energy products, there was one death associated with consumption in 2011. In the age category breakdown for energy products, of all the ages, the highest mean exposures per month were for the single age for children age 2, as well as in children from 6 to 12 years old, and in the adults aged 20 to 59. We looked at an exposure, to be linear, a regression of exposures in children aged 2 years. That's one of the prime ages that say children who ingest substances unintentionally. And you can see it appears that the number of ingestions is beginning to climb with an R-square of only 0.411. This is a little bit different than the total population of the energy product exposures. And if we want to look at medical outcomes in children age 2, we see that there were 34% of these children who had no effect, say 12% minor effect, and only to be 3 children that had what would be termed moderate effect. Now, one of the other things we did with the data was to look at all exposures. We looked at 2 symptom categories, or clinical effect categories, I should say. We looked at the central nervous system clinical effects and the cardiovascular clinical effects. This chart depicts the rank order of the energy drinks clinical effects and then compared to the clinical effects from substances that contained caffeine but were not energy products. And we can see that rank number 3 under the energy products and rank number 5 under caffeine, the clinical effect being agitated, irritable, followed by dizziness, followed by shakiness, tremor, and then headache. And these are the clinical effects continued for all the clinical effects that we tracked that we felt were demonstrative of central nervous system clinical effects. We also looked at the clinical effects comparing the energy products to caffeine, and curiously, in the energy products, rank number 4, the top, and in the exposures to caffeine, the clinical effect was to be tachycardia, followed by chest pain, followed by increased blood pressure. We did a beginning examination to correlate the clinical effects between energy products and the caffeine products, and we see there appears to be a pretty good there appears to be some correlation between the two, although these are bunches of all the clinical effects. So the energy products overall had a correlation of 0.9 or 2. So we want to do more work in this particular area to be able to look at possibly what components of energy products and other substances are responsible for the clinical effects that one sees in these calls. So what we learned from this, that we believe that energy product exposure calls to the U.S. poison centers appear to be increasing, but that initially appeared to be increasing, but now appear to be stable at the present time. But we don't have a full year in yet for 2013, and we'll need to see how this develops. Most of the energy product exposures were unintentional, followed by misuse or abuse. Agitation and irritability and tachycardia are the most frequently reported clinical effects. And 18% of the energy product calls resulted in no effect. We believe that the energy product clinical effect pattern is very similar to caffeine ingestions, but more work on this needs to be done. And the Poison Center Products Database allows for analysis of these calls by specific active agents in the energy products and in other products. And we think that more study is needed. Some of the limitations of this initial data is that these represent only self-reported exposures, whether from healthcare professionals or from the public. So underreporting is probably likely. And the exposures are confirmed by laboratory analysis only when clinically indicated. So these are not confirmed calls in the main. We'd like to make a few recommendations based on our findings for moving ahead. We believe that the Poison Center signal can be very useful in this and other questions about other products. Poison Center data can assist with data gathering on the energy products and caffeine calls by developing a prospective, focused system for data collection in cooperation with the FDA and the IOM. We think further focused analyses plus surveillance can be done on specific product active ingredients, such as taurine containing energy products. We can look more in detail at the vulnerable populations, and we think the review and further examination of the clinical effect profile of the substances, such by cluster analysis, could be very helpful. We also believe that based on the real-time nature of the data collected by poison centers, we can have a system of real-time product alerts, or case alerts rather, not case, but call alerts, to notify agencies of calls of possible public health significance. Thank you very much for your kind attention.